what we often see in perimenopause, if the woman is not being strategic and she's not doing a lot of resistance training to either add to her mass and preserve her strength and her burst training, like those type 2 muscle fibers, is it, use it or lose it, right? I was a fitness instructor. That's how I paid for my schooling. Actually, it was like I was the step instructor and whatever. And it was always like, use it, use it or lose it. Even if I had, stopped training or whatever it was for a couple of weeks and went back to the gym, I was like, oh my God, like it's really different. And that's only amplified when you're in your 40s and your 50s. So talk to us a little bit about follistatin gene therapy and how we might think about that in a woman who, and the women who are 40 and 50 now, just for some context, we all grew up, I'm 46. So we all grew up in that sort of high carb, low fat, cardio kind of environment in the 80s and 90s. So moving her to the gym, even though I'm doing my very best to educate, that there's still this very pervasive myth around getting bulky and I don't want to hurt myself and I don't even know what to do in the gym and that's for bros and it's like only meatheads there, etc. Because these women are going to be losing muscle tissue. They're going to become sarcopenic. How can we be thinking about the follistatin gene therapy that you were outlining as a maybe adjunct to, or maybe even some cases a replacement to the mechanical stimulus that we see? Or is it a viable alternative to the mechanical stimulus that you might see in the gym with lifting weights?
Yeah. Well, first off, I also worked as a gym instructor, so I come from that background as well. So that's why I have a unique lens, I guess, as a physician now. But
Same.
follistatin is definitely the closest thing we have to an exercise in a pill or exercise in a syringe in this case. So what it does at a mechanistic level is it activates activin, which inhibits myostatin, and myostatin is an enzyme that sets a limit on how much muscle you can put on. So the higher your follistatin, the lower your myostatin. So it's called an antagonistic relationship. And the reason why we like that is because by taking the brakes off on what's setting a limit on your muscle is going to allow you to obviously put on muscle easier. But most importantly, I think for the average female, it's highly anti-catabolic. So meaning it will slow down muscle loss. One of the biggest reasons as to why you have increased muscle loss is actually the same reason. Oxidative stress and chronic inflammation are probably two of the biggest drivers. And the follistatin also activates something called FOXO3 pathway. And what that does is it upregulates T regulatory cells. And T regulatory cells are definitely my favorite cells in the body because Treg cells are so important for immunotolerance. And that immunotolerance is what gets disrupted as you get older and older. And then that's what leads to immune dysfunction and leads to that chronic inflammatory state known as inflammaging. And that's what follistatin does in a nutshell. And that's why it's so profound for females, because it's going to combat that inflammation. It's going to allow you to put on muscle easier, and it's going to prevent that muscle loss that comes with aging. And of course, it increases bone density as well, which we saw in the trials because we did DEXA scans on everyone. So osteopenia and osteoporosis is well known by the public, but doctors, for whatever reason, still are not recognizing sarcopenia. It's still not considered a disease, I don't think, and for whatever reason. But our phase 2 trial we're doing for follistatin is actually for sarcopenia. So that's the specific indication. We want it to be the world's first treatment for sarcopenia and hopefully get it covered by insurance companies down the road.
Oh, that would be so amazing. Awesome. Okay, well, I have a question about that actually. So you were talking about, there's sort of this reciprocal, or maybe, as follistatin goes up, myostatin comes down. And myostatin being the sort of limiter, if you will, to the amount of muscle that you can put on. Is there another mechanism of action potentially in terms of increasing like satellite cells?
So you aren't necessarily increasing satellite cells, but you are increasing their ability to repair and regenerate tissue because you're reducing
the existing myocytes.
Yes, exactly. Because satellite cells are after you work out, there's micro tears, micro trauma that happens in the muscles. And then the satellite cells are responsible for helping the muscle to rebuild. And then over time, it gets stronger and stronger. And that's what hypertrophy is. And that's why you have to do a progressive resistance training program and periodization, because your body adapts very quickly. So if you don't change things around, then your body just adapts and gets used to it, and it doesn't have the same stimulus anymore. So to progress and add muscle becomes easier because you also are able to recover and repair better because there's less inflammation.
And are there any contraindications to this therapy? How long does it last? How often should you
So
get it?
yeah, so one injection, it's subcutaneous or intramuscular. It literally takes 2 minutes and it lasts for 18 to 24 months. And it's essentially just the follistatin is going into your circulatory system and elevating the levels for that period of time. And the only contraindication would be we don't do it during pregnancy because we haven't studied it for that yet. So not during pregnancy. And that's pretty much it. So you can do it for any other case, including even cancer potentially, because we've done it for a few cancer patients just because they become cachectic and they lose so much muscle mass.
And how is an intramuscular? So you mentioned before that the therapy is quite specific, that you can sort of code for the, for the organ or tissue or gland that you're trying to develop. So how is this sounds more systemic. So it can be an intramuscular injection, and then you're getting the follistatin levels, I would assume, in the entire skeletal system are going to be elevated, correct?
Yeah. And follistatin is highly tissue specific. So it only acts on skeletal muscle. So it doesn't affect like cardiac muscle. So, what it's doing is essentially, like we inject let's say we do it into your deltoid, so that little tissue of deltoid muscle is now transformed with the plasmid vector. And what it's doing is it's telling the cell to produce more follistatin. And then that follistatin goes into the circulatory system. So then that's why it's not editing your genome. All it's doing is transforming that local site and telling that cell to give it a set of instructions. Similar to how the lipid nanoparticle vector with the mRNA is supposed to do. But unfortunately, the lipid nanoparticle vector is immunogenic and there can be off-site targets. And we know that now. So if you can just read it, it's published out there. It's not, me making it up. So lipid nanoparticle vector is a vector that Moderna and Pfizer use. And the problem is that there's off-site targets and it's immunogenic. And that's why we see some weird side effects with the vaccine. And whereas with the plasmid vector, the mini circle vector that we have, it's non-immunogenic and there's no off-site targets. So at least we know we have that safety mechanism built into it and we can feel confident we're not doing something we're not supposed to be doing.